Next speaker is Dr. Arya Chandran, free paper 50.
Good afternoon all. Our study is on predicting macular edema recurrence in branch retinal vein occlusion using choroidal thickness. Aim of our study was to analyze the relationship between changes in choroidal thickness and recurrence of macular edema in branch retinal vein occlusion. So, macular edema occurs in 90% of BRVO cases. That is, vascular occlusion or hypoxia increases the level of vascular endothelial growth factor and interleukin 6, causes breakdown of blood retinal barrier by damaging the tight junctions of capillary endothelial cells, causing fluid flux from vessels to tissue. So, the macular edema comes in action. The vascular endothelial growth factor expression in retinal pigment epithelial cells, pericytes and microvascular endothelial cell produces nitric oxide, causes vessel dilatation and increased ocular blood flow, so the choroidal thickness increases. It was a prospective study conducted among 46 patients of 46 treatment-naive BRVO patients with macular edema who underwent at least one dose of intravitreal anti-VEGF injection and followed up for a period of 6 months during a study period of 1 year. And we have analyzed central choroidal thickness, baseline and 1 month after injection by measuring manually at fovea from the hyperreflective Brooks membrane to hyperreflective choroidoscleral interface using OCT Heidelberg Eye Explorer software, and central subfield thickness, which is a circular area of 1 mm diameter centered on the center of the fovea with this macular thickness provided as a quantifiable data on OCT software, which was measured every visit, and CSFT more than 300 micrometer was taken as the criterion for macular edema recurrence. And study population was categorized into Group A and Group B. Group A, patients with macular edema recurrence, and Group B, there is no recurrence of macular edema. That is, after 1 month of intravitreal injection, there is macular edema, and during the follow-up of 6 months, there is no macular edema recurrence. And the Group A was again divided into Group A1 and Group A2. Group A1, there is no complete resolution of macular edema at the end of 1 month of intravitreal injection, and Group A2, there is resolution of macular edema at the end of 1 month of injection, but there is recurrence of macular edema during the follow-up period of 6 months. Results. About 55% patients show no recurrence of macular edema, and 45% patients show recurrence of macular edema. This graph shows the relationship between baseline central choroidal thickness and macular edema recurrence rate. Patients with the baseline choroidal thickness of 281 to 330 micrometers show high macular edema recurrence rate. This graph shows the relationship between the percentage reduction in choroidal thickness and macular edema recurrence in Group A. Here we can see the patients with less than 6% reduction in choroidal thickness after 1 month of intravitreal injection show high macular edema recurrence rate. This graph shows the relationship between percentage reduction in choroidal thickness and macular edema recurrence rate in Group A1, that is, no resolution of macular edema at the end of 1 month of intravitreal injection. Here also the patients with less than 6% reduction in choroidal thickness after 1 month of intravitreal injection show high macular edema recurrence rate. This graph shows the relationship between percentage reduction in choroidal thickness and macular edema recurrence rate in Group A2, that is, no macular edema at the end of 1 month of intravitreal injection, but there is recurrence of macular edema during the follow-up period of 6 months. Here the patients with 7 to 30%, that is moderate reduction in choroidal thickness after 1 month of intravitreal injection show high macular edema recurrence rate. Coming to discussion, in our study we have found that higher baseline choroidal thickness and lesser the reduction in central choroidal thickness, there is a high risk of recurrence of macular edema. The similar studies conducted by the Okama et al. Showed baseline central choroidal thickness was significantly thicker in recurrent group than the resolved group. And the Visama et al. Showed central choroidal thickness of 300 micrometer was significantly higher in recurrent group compared to response group. And Oshiho et al. Showed macular edema recurrence was lower in cases of treatment-related choroidal thinning. To conclude, even though retinal layers are primarily involved in retinal vein occlusion, choroidal changes have a predictive value in recurrence of macular edema. Most of the patients with branch retinal vein occlusion showed complete resolution of macular edema after first dose of intravitreal injection. So, all the BRVO patients do not require multiple doses of intravitreal injection. And higher the baseline central choroidal thickness and lesser the reduction in central choroidal thickness, there is increased risk of recurrence of macular edema. And moderate reduction in central choroidal thickness increases the chances of recurrence of macular edema following complete resolution of macular edema after 1 month of intravitreal injection. Those patients require frequent follow-up counseling and multiple doses of intravitreal injection. These are my references. Thank you.
Which branch, man? You told BRVO, BRVO. Which branch is involved?
All the branches.
Nasal branch involved, you can get macular edema.
Supratemporal and infratemporal.
I am asking you all the branches you hold.
Sir?
You told all the branches. What about supranasal quadrant if it gets involved?
Yes, sir.
You can get macular edema. Supranasal branch is blocked.
Only with the patients with macular edema.
That means when you are telling macular edema, you should have told which branch was involved. At least should have, because macular drains normally to which vein, know that?
So all the BRVO patients with the macular edema.
No. Macular drains into which part of the vein? Which vein normally?
Sir,
Macula drains into which vein? The tributary from macula enters which vein is more commonly?
Supratemporal.
Then you should have told at least supratemporal vein occlusion or both. Superior and inferior temporal. You are telling all the branches, no?
Most of the patients were supratemporal.
You should mention which branch.
Okay.
BRVO means for I can, for fun, no, we'll tell you why can't be inferior nasal branch.
Okay.
You must be specific.
Okay.
And you have not shown any picture about the macular edema. The fantastic picture and all you have not shown.
Okay.
Understand now?
Yes, sir.
These are all some of the drawbacks. Otherwise, okay. And letters are all very small. That to the references I saw, no? Okay. You might have taken the dissertation page, no?
Yes.
This is your dissertation.
No, sir.
Thesis. Thesis book paper, no? This is dissertation.
Part of the
dissertation. That's why your references you are taken from dissertation book. That's why they are all very small.
No, sir, I want to include in one page. That's why the.
No, that is you can include there. Where in your thesis book. It's a slide, suppose a person standing and sitting last row, you cannot see anything. Always you must include very few lines and slightly, at least 40 size.
Okay, sir.
When you prepare PowerPoint, you must have at least 40 font size.
Okay, sir.
Then only everyone can see.
Okay, sir.
This is a normal, not blaming and all.
Okay.
Just an advice. Hereafter when you prepare PowerPoint, you have to be like this.
Okay.
Thank you.
Okay.
Can you measure choroidal thickness in all OCT machines?
All OCT
Machines.
By my yes, sir. Using the OCT Heidelberg Eye Explorer software, we can measure.
Okay, recently all machines have this technology. Okay.